My name is Chris Bradburn. I'll be the host for this session here. Again, this is session 152, radioiodine refractory non-avid thyroid cancer, novel redifferentiation therapies. Let me go ahead and introduce our speaker today. Dr. Boucai, MD, is an internist and endocrinologist at the Memorial Sloan Kettering Cancer Center in New York City, New York. Dr. Boucai completed her internship and residency at the New York Presbyterian Hospital, Weill Cornell Medical Center, and was a fellow in endocrinology and metabolism at the Albert Einstein College of Medicine, Montefiore Medical Center. As part of her academic career, she spent 4 years as a faculty member at Albert Einstein College of Medicine and is currently an assistant professor of medicine at Weill Cornell Medical College. She's an active member of the Endocrine Society, the American Diabetes Association, and the American Thyroid Association. Her research interests are focused on achieving a better understanding of the pathogenesis of thyroid cancer. Welcome, Dr. Boucai. The stage is yours.
Thank you so much, Christopher. Laura Boucai. I think that bio is a little outdated. I was promoted to associate professor, so I'm a little bit higher up in the ranks of Cornell, but here I am. So I'm going to talk to you about radioiodine refractory thyroid cancer and novel redifferentiation therapies. And my objective, honestly, is that we have some kind of understanding of what radioiodine refractory disease means, because we talk a lot about what it means, but we don't really have a whole bunch of definitions that we can put clear in our minds to understand what is it that we define it as, the mechanisms of redifferentiation, and the treatments that we have available to use in our patients. So I have nothing to disclose. And I wanted to start with a case because I think that many of you will relate to this case and maybe it will make things easier to understand. This is a 67-year-old woman who presents with a vertebral fracture. They see a mass in the spine, they biopsy it, and it comes back poorly differentiated carcinoma of thyroid origin. She goes through a PET scan that shows 2 bone lesions in the spine, lung nodules, and a 3.5 nodule in the right thyroid. She has radiation to the spine. She has a thyroidectomy, and the post-operative thyroglobulin is undetectable, which is very common in our poorly differentiated thyroid cancers. If everybody knows, if you've been following your thyroid cancer for years, you know that the thyroglobulin level is your thyroid cancer marker, and some tumors make more of it and other tumors make less of it. In the case of poorly differentiated thyroid cancers, which look under the microscope a little bit different than normal thyroid tissue, and that's the reason why we call them poorly differentiated, because they don't resemble normal thyroid tissue that much. They have the tendency to make less thyroglobulin and to concentrate less radioactive iodine. So despite this, the patient receives 200 millicuries of radioactive iodine. But interestingly enough, the scan after the whole therapeutic dose of radioactive iodine is negative everywhere except for the thyroid bed where the thyroid used to lie. 6 months later, the thyroid cancer marker continues to be low, but the chest CT shows that her lung nodules are growing from 5 millimeters to 9 millimeters, and the spine lesions that had received radiation are stable. A year after the surgery, her chest CT shows that the lung nodules are growing even more to 1.2 centimeters in size, and still the thyroglobulin level is low with a low TSH. The patient goes through a radioiodine scan to see if any of these picks up iodine, and the radioiodine scan is negative. So this case exemplifies of what we call radioiodine refractory. What are the instances in which we can define something as radioiodine refractory? Well, when there is lesions that contain thyroid cancer that do not pick up iodine on a diagnostic scan, that's called radioiodine refractory. When there are lesions that do not pick up iodine on a post-treatment scan, and we knew that this person had lesions in the lung and lesions in the spine after receiving 200 millicuries of radioactive iodine, well, that's also tissue that's probably radioiodine refractory because it does not concentrate radioactive iodine. When there is thyroid cancer or lesions of thyroid cancer that grow despite iodine administration, even if they pick up iodine, well, that's called radioiodine refractory. So we can imagine a case of a patient who receives radioactive iodine, the lung nodules concentrate radioactive iodine, but despite that, the lung nodules start growing over time, and even though they did pick up radioactive iodine. I see that there are questions coming in. So Christopher, if you feel like interrupting me and ask me a question in the middle of where I'm talking, just feel free. Otherwise, I'm going to continue, and then we go through the questions at the end.
Sounds good. Keep going.
Tumors that receive more than 600 millicuries of radioactive iodine without signs of shrinkage or remission are also considered radioiodine refractory, because it is believed that 600 millicuries is a dose high enough for tumors to have responded to this amount of radioactive iodine. And if despite this, the tumors do not shrink, well, that's probably radioiodine refractory disease. And in general, these tumors are poorly differentiated. What does that mean? That they do not resemble normal thyroid tissue, like I was saying before. They do not produce good amounts of thyroglobulin, and so we cannot really trust this thyroid cancer marker. And it is avid on FDG PET scans. So that's another modality of how we scan patients that has nothing to do with radioactive iodine. But on PET scan, they are very, very bright. In general, these tumors respond less to radioactive iodine. And so how does a thyroid cell become radioiodine refractory? Well, it turns out that at the edge of the cell, we have a symporter called the sodium iodine symporter. And this sodium iodine symporter transports 2 molecules of sodium and 1 molecule of iodine inside the thyroid cell, which is represented by these purple dots. When these purple dots get inside the thyroid cell, they destroy the thyroid cell from within. And when the transporter of the radioactive iodine is not expressed in the thyroid cell, in the membrane of the thyroid cell, in the edge of the thyroid cell, the cell can become refractory. The cell does not have the ability to incorporate radioactive iodine or to have the radioactive iodine access the cell and kill the cell from inside. And what are the reasons why this transporter may not be located at the edge of the cell, in the membrane of the cell? Well, it turns out that cells have signaling mechanisms inside of them that make these transporters go up the cell. When there is a lot of signaling going through this pathway, which is called the MAP kinase pathway, this transporter of iodine goes down. It does not get expressed in the membrane of the cells. And so many cells with a lot of outflow through this MAP kinase pathway downregulate or make the transporter not be present at the edge of the cell. So the cells cannot absorb or incorporate the radioactive iodine. And so one of the strategies that we have to bypass this problem, or to make the transporter go back to the cell membrane to be able to incorporate radioactive iodine, is blocking or inhibiting the mechanisms by which this effect is produced. So if we know that a lot of outflow through this pathway produces a low transporter of iodine in the cell, well, blocking this pathway will generally make up for more transporter at the edge of the cell that will allow incorporation of the radioactive iodine. And I'm going to show you an example. So this is the same pathway that I was talking about, the MAP kinase pathway, with the drug selumetinib that causes blockage of MEK. MEK is one of the proteins downstream inside the cells. And it turns out that when we block MEK, the sodium iodine syn porter that incorporates iodine into the cell appears more in the cell membrane. This is a patient at baseline without any of this selumetinib, and this is a patient after receiving 4 weeks of selumetinib, the same patient with this MEK inhibitor. And you can immediately see that the lung nodules with thyroid cancer incorporate much more radioactive iodine with this inhibitor than without this inhibitor. This is what we call redifferentiation. Redifferentiation is making the cells absorb more radioactive iodine when originally they did not pick up radioactive iodine. That's what redifferentiation means. Make the cells differentiate into more normal looking thyroid tissue. And obviously, there was a trial on this, and the structure of the trial was the following. The patients would have an iodine scan at the beginning of the trial, and we would see a little bit of iodine being picked up or almost no iodine being picked up in metastatic thyroid cancer. They would get this drug for 4 weeks, and then they would have an iodine scan at the end of the 4 weeks to see how much iodine would have been picked up in these metastatic cells. And a fraction of the patients actually redifferentiated quite well. In the table below, you can see that out of 9 patients with a BRAF mutation, 4 patients actually ended up picking up more radioactive iodine. Out of 5 patients with a RAS mutation, all 5 of them ended up picking up radioactive iodine. And this was fantastic because we were able to suddenly treat these radioiodine refractory RAS mutant patients, and these are patients with a specific genetic mutation in one of the proteins inside that MAP kinase pathway, that we are able to suddenly make absorb a lot of iodine. So all 5 of these patients picked up iodine and were able to receive radioactive iodine. And these are some of the most dramatic cases that we have had. This is at baseline, a patient with metastatic lung disease that in the initial iodine scan, you don't see the lung metastasis, but in the follow-up iodine scan after 4 weeks of the MEK inhibitor of the selumetinib, the lung metastasis pick up iodine. This is another patient, again, with lung metastasis and how the lung metastasis end up picking up iodine. This is a bone metastasis, and these 2 examples are for you to understand that the thyroid cancer cell can be located in soft tissue like lung or in bone tissue that is much harder to penetrate and much less vascular. And so these lesions also redifferentiate and pick up more radioactive iodine when we give them these MEK inhibitors, this selumetinib. And this is a chart of the responses that we've had. You remember that there were 5 patients with this NRAS mutation, which is a specific genetic mutation that patients have. Well, out of the 5 patients, 4 of them had a partial response and 1 of them had stable disease. And a partial response means that the lesions actually shrunk structurally, and we were able to see lesions decreasing in size. 1 BRAF patient who received radioactive iodine also had a partial response to the dose of radioactive iodine after the selumetinib. And invariably, all 8 patients who ended up receiving radioactive iodine lowered their thyroid cancer marker dramatically. Even one of them went from a level of 530 to undetectable levels of thyroglobulin 6 months after receiving radioactive iodine. So this shows you that we are able to redifferentiate tumors. We are able to make the cells absorb a lot of radioactive iodine and concentrate radioactive iodine so they are amenable or susceptible to being killed from inside. But obviously, you guys saw that only 1 of the 9 patients was able to receive radioactive iodine when they had a BRAF mutation. And BRAF mutation is one of the most common mutations that thyroid cancer patients have. And so the idea became, what if we give them a BRAF inhibitor? Would that work better? So we tried that, right? And we used vemurafenib, which is a BRAF inhibitor, for 4 weeks. Same design. Patients would have an iodine scan before, vemurafenib and BRAF inhibitor for 4 weeks, and an iodine scan after. From the patients who redifferentiated or picked up iodine in the second iodine scan, if they had a threshold enough to receive radioactive iodine, they would go ahead and receive radioactive iodine. If the lesions did not pick up iodine in the second iodine scan, because there are patients who, despite 4 weeks of the BRAF inhibitor, still do not concentrate good amounts of radioactive iodine, the medication is discontinued and the patient is not eligible to receive another dose of radioactive iodine. And these are the results. A lot of BRAF mutant patients redifferentiated, and lesions that we could barely see in the baseline scans were very bright on the follow-up scans. And this is another patient with very low uptake of iodine in baseline and very high uptake of iodine afterwards. And one of the things that we learned from these trials were that we are able to test each lesion to understand how differentiated this lesion is. The more differentiated this lesion is, that is, the more they resemble normal thyroid tissue, the more we are able to redifferentiate them or to make them look like normal thyroid tissue. But if the lesions are very dedifferentiated and do not resemble at all normal thyroid tissue, then our ability to differentiate them is much less. And we can test that lesion by lesion. You can see here that from baseline to after 4 weeks of vemurafenib, this lesion picks up iodine, but not so much. So we are not as successful as making the lesion absorb good enough amounts of radioactive iodine. And so in this trial of 10 patients, 6 patients increased the uptake of iodine and 4 patients ended up receiving radioactive iodine. 2 had a partial response and 2 had stable disease, suggesting that this is a viable strategy to target patients with BRAF mutations. Now, the idea came up to suggest, well, if our patients can tolerate a MEK inhibitor and a BRAF inhibitor, why don't we combine the two? BRAF inhibitors plus MEK inhibitor, maybe it's more effective than each of the two together. And this would make tumors absorb radioactive iodine even better. Well, this idea took up everywhere in the world. And so there was a trial in Boston. There was another trial in Boston, Ohio State, and MD Anderson, among others, that tested the hypothesis that a BRAF inhibitor along with a MEK inhibitor was able to redifferentiate tumors. And in this one, in particular, 6 out of 10 patients had a partial response or stable disease. In this one, 50 patients had a partial response or an overall response rate with the BRAF alone, and 54% of the patients had an overall response rate with BRAF plus the MEK inhibitor, suggesting that these have very high effectiveness at redifferentiating lesions when we know the genetic mutation that they arise from. At the moment, there are tons of studies being conducted at in France, Gustave Roussy, with the addition of radioactive iodine in MEK and BRAF inhibitors, on BRAF inhibitors and HER3 inhibitors. This is one of the inhibitors of one of the resistance mechanisms that can arise after using these drugs for a while. And at MSK, there are other trials happening with BRAF inhibitors plus PI3 kinase inhibitors, which are the other side of the signaling pathway that I showed you inside the cells of thyroid cancer. So, you know, I'm gonna keep it short, and I want to allow a lot of room for questions because I see them accumulating in the chat. And so I wanted to give you the background for you to start asking. So in conclusion, it is important to define and recognize what radioiodine refractory disease is in general, we wait to treat this disease until we see structural progression. Not every radioiodine refractory disease needs to be treated right away. In general, progression of disease dictates our use of these redifferentiation therapies. A single MAP kinase inhibitor is effective at redifferentiating tumors based on genotype, and the combination of inhibitors are also effective and maybe even more so than the single treatment. Redifferentiating drugs have the potential to destroy cancer cells, so current attempts are to optimize the duration of their use. We don't know whether 4 weeks of this or 8 weeks of this may be better, or even 3 months of these drugs may be even better for our patients. And what we are in front of here is the possibility to use these drugs for a very short period of time, minimizing the side effects that we can get on these drugs, followed by the use of radioactive iodine, and eventually we could potentially use them again in the future to avoid resistance of to these drugs that we're using. So with that, I am actually going to stop and answer all these questions that became accumulated in the chat. So let's go ahead. Chris, I'm going to rely on you to either I can read the questions or you can read the questions to me.
Okay, I can read them. Here's the first one. Both the low dose RAI scans and my FDG PET CT scans have been coming negative, whereas the malignant lymph nodes are being confirmed by NECT ultrasound and FNAC. Should I go for a high dose RAI therapy in the hope that the malignant lymph nodes were not absorbing when a low dose was used and will be absorbed in a high dose?
So, no. The short answer is no. And the reason why I say no dramatically is the following. We need to see the extent of thyroid cervical lymph nodes, of neck lymph nodes detected on the neck ultrasound. When the neck lymph nodes are very tiny, they may not concentrate radioiodine or FDG glucose on the PET scan simply because they are small, they are tiny, and we have to wait for them to grow, and we have to wait for them to grow a little more. So chances are that if you cannot see them on the radioiodine scan, or you cannot see them, somehow the question disappeared. Oh, here it is. If you cannot see them on the radioiodine scan, or you cannot see them on the PET scan, well, they may be too small. They may not concentrate radioactive iodine, but also the high dose radioiodine may not be the appropriate treatment to cure these lymph nodes, and you may need a repeat surgery for these lymph nodes. If you already received radioactive iodine and the first robust dose of radioactive iodine didn't get rid of these lymph nodes, and these lymph nodes are growing and progressing, well, maybe we need a surgery and a completely different approach than what we are thinking. But another more robust dose of radioactive iodine, or a high dose radioactive iodine, will not solve the problem that the initial dose of radioactive iodine did not solve to begin with. Hope I answered that one.
Excellent. Next question we have is papillary hobnail RAI refractory?
Is papillary hobnail radioiodine refractory? We don't know, right? Because the pathology does not define refractoriness. Refractoriness is defined by the tumor being not concentrating radioactive iodine here. The tumor not concentrating radioactive iodine on an iodine scan and still progressing. The tumor progressing despite a therapeutic dose of radioactive iodine. The tumor, even if it concentrates radioactive iodine, progressing and growing. So there are many hobnail features that may make the tumor a little bit more aggressive and not concentrate radioactive iodine, but that will be determined on the progression of the disease. If you have had papillary thyroid cancer hobnail variant resected from your neck and it never came back again, you may be just fine, and you may never know whether the tumor is radioiodine susceptible or refractory. So it depends on the behavior in the future of particularly metastatic disease, whether you can define your Hobnell variant papillary thyroid cancer refractory or not refractory.
Okay. This is a follow-up to the same question. Is papillary Hobnell TG reliable? Is it a good candidate for redifferentiation therapy?
Is papillary Hobnell TG reliable? Is it a good candidate for redifferentiation therapy? Again, same story, right? So the good candidate for redifferentiation therapy depends on the genetic mutation that drives the progression of the tumor. Hobnell variant papillary thyroid cancer may be BRAF positive, or they may be RAS positive, or they may have a fusion mutation. So remains to be genotyped. And this is one of the things that probably I wasn't that clear on my presentation, but we tend to use these redifferentiation therapies targeted to the genetic mutation or the protein that is mutated inside the thyroid cell. I showed you this MAP kinase pathway with a ton of proteins that could be mutated inside. Well, genotyping the tumor and understanding what gives rise to these papillary thyroid cancers is what would make the decision of whether the tumor or the patient is a candidate for redifferentiation therapy with a targeted therapy. The thyroglobulin level may not be as reliable as in classical type papillary thyroid cancer, but there are a ton of Hobnell variant papillary thyroid cancer that produce significant amounts of thyroglobulin, and the thyroglobulin grows when there is disease growing. Other patients may have thyroglobulin not responding to structural progression of disease.
Off clinical trials, do you treat patients with non-BRAF mutations with redifferentiation therapy?
Non-BRAF mutations, so that is RAS mutations or NTRK inhibitors or stuff. At Memorial, we tend to treat patients within clinical trials, but we understand that there are other institutions where there is the possibility of treating these patients with redifferentiation therapies outside of the clinical trial. So that is a possibility. Certainly, there are patients with RAS mutations that receive trametinib and radioactive iodine. We have done it. We want to collect the experience of how the patients respond in the context of a clinical trial, if preferentially, just because it's easier for us to understand how effective this is. But it's evident that if these therapies are working really well, we're going to extend that outside of clinical trials in the hopes that these drugs get approved for that use. They are not FDA approved for that use.
Do Hürthle cells respond to medication to assist in taking up RAI?
So it depends on the genetic mutation of the Hürthle cell. The Hürthle cells have a complex genotype. So there are, chromosomal abnormalities in Hürthle cells that cannot be overcome with a single medication that makes them respond better to radioactive iodine. So in the case of these chromosomal abnormalities, it is a little bit more challenging for us to redifferentiate Hürthle cell cancers. But there are trials underway with everolimus and other drugs that are targeted to Hürthle cell cancers with the idea of attempting to redifferentiate these tumors. So I think that the question is related to, do we have medications to overcome the problem with chromosomal abnormalities that happens in Hürthle cells? No, at the moment we don't. So the medications would only be used to those Hürthle cells that are driven by RAS mutations, and that we have medications to inhibit RAS and redifferentiate with radioactive iodine.
Okay. Would you recommend inhibitors for a young male patient, stage 2, or external beam radiotherapy? And then follow-up is there a genome testing that one can undergo to test for RAI refractory gene mutation? So two-part.
So for the, let's go part two first.
Okay.
So for the radioiodine refractoriness, depends on the behavior of the tumor, regardless of the genetic mutation that the tumor carries. So it's the way that the tumor responds to having received radioactive iodine or to not concentrating radioactive iodine. That's what radioiodine refractoriness means. The genetic mutation of the tumor is essential for us to redifferentiate the tumor with the right medication, because if we give a BRAF inhibitor to a RAS mutant patient, it may not respond as well as if we give them a RAS inhibitor. And so the reason why we use genetic testing of the tumor to understand which genetic mutation drives the progression of the disease is to give the appropriate medication to these tumors in the event that they become radioiodine refractory. So the question is there a genome testing that one can undergo to test for this? Yes, there's panels, commercial panels, and there are institutional panels in any cancer center that can test for these genetic mutations of the particular tumors. Now, the first part of the question is, would you recommend inhibitors to a young male patient, stage 2? So stage 2 is metastatic disease in young people. And the question is very loaded because obviously we have no idea where the metastasis is located. And so the young person could have a single metastasis in the spine for which you would radiate with external beam radiation and solve the problem right away. Or the person may have lung metastasis that may not progress for decades to come. And so in young patients, what we see is tons of lymph nodes, lung metastases that we can observe for a very long period of time without treating them. And so at this point, an inhibitor would not be indicated because the lesions are not progressing. Now, if the lesions are growing, like I showed you in our case, from 5 millimeters to 9 millimeters to 1.3 centimeters in size over a course of 6 months to a year, that's when we start thinking of treating these patients with redifferentiation therapies and with this radioactive iodine treatment. And then external beam radiation therapy is a completely different question for a completely different disease. And we typically apply it either to focal lesions in the spine or in the bone that do not necessarily respond to radioactive iodine and that are single and cannot be resected with surgery, or to elderly patients, not young patients, with very invasive, locally invasive disease of the tumor in the neck, with that invades critical structures in the neck that you want to prevent from the tumor growing into, like the trachea or the esophagus. We would indicate external beam radiation therapy, but there's a lot of questions in that questions. So you know, let's yeah, I hope I answered a little bit of that.
Can RAI kill dormant thyroid cancer cells?
Yes. I don't know what you mean by dormant, but if you mean microscopic thyroid cells that you cannot see or detect to the naked eye by looking at an ultrasound, yes, radioactive iodine can sometimes destroy these cells and you can see the thyroglobulin level going down, but you cannot really see the cell there. So, I mean, if you can clarify what you mean by dormant, I can answer your question better.
I was submitted anonymously, so hopefully they'll respond back with more information.
Okay.
Is there a thyrogen level that you would think is not reflective of poorly differentiated thyroid cancer? So it seems to be controversial diagnosis if someone has TG of 300 or say 1000.
The thyroglobulin level has nothing to do with is there a thyroglobulin level that you would think is not reflective of a poorly differentiated thyroid cancer? No. So there are multiple definitions of poorly differentiated thyroid cancer, and one of them is the definition that was done at Memorial, where you see the cells having a lot of necrosis and mitosis. That is, the tumor is replicating and dying. And some of these tumors produce a ton of thyroglobulin. You can have thyroglobulin levels of 1,000 and the tumor can still be a poorly differentiated thyroid cancer. In general, what I was trying to explain in the case that I showed you is that these tumors tend to produce little amounts of thyroglobulin that do not correlate with the burden of disease that you detect on CAT scans. That's the relationship of thyroglobulin. But some poorly differentiated thyroid cancers do produce thyroglobulin, and if it does, good for you. You can trust them and you can follow it over time, and if it tracks along with structural progression, if the radioactive iodine is working, you should see the thyroglobulin level going down.
This is sort of a related one. What is a significant level of thyroglobulin?
Significant for what? We're New Yorkers. We don't get we are not scared of any thyroglobulin level. You can show me a thyroglobulin level of 20,000 or a thyroglobulin level of 5, and I will be the same scared. So I don't know what you mean by significant. Not sure how to answer that one, because significant may be high for some people, low for others. So I think that the most important part of that question is never look at a single point in thyroglobulin. I tell all my patients, make your Excel spreadsheet and track. Oh, my lovely patient is among all the questions here. And so he keeps his thyroglobulin antibodies and thyroglobulin levels tracked on an Excel spreadsheet, and shows me how the thyroglobulin antibodies have gone up or down over time. And so the thyroglobulin, more than the absolute value, is the trend of where it's going. If it's going up, you get worried. If it's stable, you take a nice deep breath. And if it's going down, you are reassured that things are going in the right direction. Excellent.
Is there a certain level of PET avidity that correlates with RAI resistance? Any particular SUV value?
Yeah, so above 5, we don't like it. When things are very avid on PET scan, they tend to be more radioiodine resistant. This is not written in stone. This is not published in the literature, but in general, high SUVs, 10, 20, 30 SUVs on the PET scan are likely not to respond that well on radioiodine, to radioactive iodine.
And the person got back to us on the what they meant by dormant. They said dormant in the sense that the cancer cells are resistant to treatment, has the capability to evade treatment. So that would...
help me out here.
I'm trying to find the original question here. Yeah.
In the sense that the cancer cells are resistant to treatment.
The original question was, can RAI kill dormant thyroid cancer cells?
Can RAI kill resistant thyroid cancer cells? Well, if they are resistant, it cannot be killed. So you tend to want to give them medications to redifferentiate them. I think we're getting confused with the word dormant, which it's not part of our vocabulary. But if dormant, you mean resistant to radioactive iodine, that's the very definition of no, it's not going to respond to 3, 4, 5 doses of radioactive iodine, and that's the reason why you will use these medications. Okay.
Have you or will you be publishing the Memorial Sloan Kettering Cancer Center experience on patients treated with redifferentiation therapy off clinical trials to see what the real world experience is?
Wow, you're reading my mind there. So we are collecting we're going to collect the experience. We truly have not gotten organized enough to collect this. In fact, there hasn't been that many patients off trial being treated to publish the experience just yet. And so we really need a couple more years to understand how these patients really work. But yes, it would be very nice to understand how these drugs work outside of a clinical trial. Yeah, and that's coming, but I think we are in early stages. Mm-hmm.
How do you decide whether to treat with just BRAF inhibitor versus a RAF inhibitor combined with a MEK inhibitor?
Well, so it depends on the toxicity and it depends on the additional mutations that the patients might have. So our patients may have a BRAF mutation alone, or they may have a BRAF mutation with a PI3 kinase mutation with another kind of mutation that we know we may have inhibitors for, and we may want to combine both of them. Sometimes it's just a trial and error, and we use a BRAF inhibitor. They don't respond to the BRAF inhibitor alone, but they do respond to the BRAF plus MEK inhibitor. And so we do the first go around. If it doesn't respond, we do the BRAF and MEK inhibitor. But in general, we want to make those decisions based on the genomic profile of the patient. If we can target multiple genetic mutations at the same time, that would be ideal.
Excellent. Can redifferentiation be done for PTC even if there is no thyroid-specific gene mutation, but the overall tumor mutation burden is high?
Well, yeah, that's sci-fi, right? So we can try and we can throw in an inhibitor of this MAP kinase, but if you don't know what you are redifferentiating, then it's like a blind test. We in general do not like to do that. So you don't have a specific mutation, but if the tumor is progressing fast and it's becoming a very aggressive tumor, yes, you're gonna try and do dabrafenib, trametinib. You're gonna try to use some of these medications that I have been talking about, even without knowing the specific tumor profile. But in general, we don't like that, and it's not clean, and we don't know what we're doing. So in general, we don't do that, and we don't have experience doing that because it mechanistically it doesn't make any sense. But I understand that in a desperate attempt to control a tumor that's growing in the absence of a genetic mutation that gives rise some progression to the tumor, you may want to do that. Yeah.
Are there any studies that address a PTEN deletion genetic mutation?
Not yet, like medications for a PTEN deletion, not that I know of.
Wonderful presentation. Will there be any clinical trials for patients who are not BRAF mutated to assess if we are candidates for redifferentiation?
There are currently for RAS mutant tumors, for NTRK mutant tumors, for RET mutant tumors. So there are a lot of other mutations that are not BRAF that have the possibility of being treated with these genetic inhibitors. So stay tuned, yes.
How large do lesions nodes have to be in order to test for inhibitor, to test if the inhibitor is working?
So, I'm going to turn around that question, because it's not that the lesion has to be a certain size. Technically, in our clinical trials, we have a very specific measurement of RECIST criteria, and this is a radiologically defined criteria where the tumor has to be 1 centimeter big or bigger than that for us to be able to detect a 30% decrease in the volume or in the size of the tumor. And so it's not that the lesion has to be a certain size for us to use the inhibitor. It is that traditionally the eligible patients have been enrolled in our trials with a RECIST measurable disease, which has to be 1 centimeter or more. Now, there are patients who can be treated off trial that are progressing, and we don't necessarily use the cutoff of 1 centimeter, but we tend to respect that cutoff, because if they don't, you're treating very microscopic disease, very little disease. And so in general, we try to wait for the lesions to enlarge or to show some sort of progression that is measurable over time for us to be able to understand whether the inhibitor works or doesn't work. If you test a lesion that is at 6 millimeters in size and you use an inhibitor and it decreases to 5 millimeters in size, you're really not going to know whether it's your variation in the size that you're measuring or if your inhibitor is truly working.
Excellent, thank you. How do you diagnose refractory disease when you have a stable low, when you have had stable low levels of thyroglobulin for many years and no uptake in low dose RAI scans?
You don't, right? So stable low dose of thyroglobulin, no uptake on iodine scan. The disease is not structurally or biochemically progressing. That's not radioiodine refractory disease. Radioiodine refractory disease would be such that it would have been treated with radioactive iodine and it's structurally progressing. So you see lung nodules growing over time, even though the thyroglobulin level may be 0.2 or 0.3 because the tumor is poorly differentiated and it's not making enough thyroglobulin. You have to see a structural progression of disease. We never treat a thyroglobulin level. We neither treat a value, we treat a lesion of thyroid cancer getting bigger. That's how you diagnose radioiodine refractory disease. And yes, it's not going to have uptake on the iodine scan, and it's going to progress despite the robust dose of radioactive iodine in the past.
Excellent. Just a time check here, about 10 minutes away from the end of the session here. We're more than halfway through the questions. I know. My TG was 101 prior to RAI. After thyrogen, it went up to 967 prior to the RAI dose. Does this mean my burden of disease is large, or what does it mean?
It means that your tumor makes good amounts of thyroglobulin, and if you stimulate it with TSH, you have the ability to produce a lot of thyroglobulin. So you may use your thyroglobulin level to track it over time. And if radioactive iodine works, you will see your thyroglobulin level going down from 101 to 60 to 30 to 10, and hopefully to lower levels. As far as the burden of disease, you may have different burdens of disease, but if the tumor is really well differentiated and you make a ton of thyroglobulin, you may have a lung nodule measuring 1 centimeter in size, producing a thyroglobulin level of 101, and you still may respond. The fact that it went up to 964 says that you probably have some lesions of thyroid cancer making a ton of thyroglobulin, but it cannot really give you an accurate picture of the burden of disease. There are different burdens of disease that can give you the same levels of thyroglobulin.
My radioactive iodine dose was 164. 4 months later, my thyroglobulin is 8.4. Does this mean I am resistant to radioactive iodine?
No. You may have started with a thyroglobulin level of 1,000 and now it's 8.4, and in another 6 months it's going to be 3, and then in another 12 months it's going to be 1, and hopefully it will be undetectable afterwards. So no, I wouldn't say that somebody is resistant to radioactive iodine from a persistently detectable thyroglobulin level. Again, it's more important to follow the trend in the thyroglobulin more than the absolute value of the thyroglobulin. And it would become resistant if that thyroglobulin level in another 6 months or a year becomes 12 or 16 or 20, and you see structural growth of something that you thought you were shrinking with the radioactive iodine.
I have a BRAF V600E mutation and the disease is persistent. My doctor has recommended one of these therapies. Do you have any advice?
Well, I would need to see where the disease is persistent. I would need to see if the lung nodules are growing or where the disease is located. Sometimes if the disease is contained to the neck, we recommend the repeat surgery rather than one of these therapies. If the disease is everywhere in the lungs or in the bones, we may recommend redifferentiation of these therapies. Yeah, I truly cannot answer that question because you have to evaluate the entire structural burden of disease to recommend or not recommend one of these therapies. You have to understand what's the disease, what you're targeting, and what you aim to shrink and destroy. Okay. And if it's growing, most importantly.
What are some of the side effects of using these inhibitors?
So the most common ones are rashes in the skin, elevated liver enzymes, diarrhea, and problems with rashes in the hands and in the feet. There are hypertension and some EKG abnormalities are some of these problems too, but the majority of patients tolerate these inhibitors rather well. They complain of the rash. Rashes can be very annoying and debilitating, and some minimal elevations in the liver, inflammation of the liver.
What if you had a genomic test and no mutation showed up?
Well, I think we targeted that one. I think that no mutation showed up. You continue to try and identify what genetic mutation gives rise to this tumor. If the tumor continues to progress despite the absence of an identifiable genetic mutation, you may elect to treat with one of these inhibitors, but you're in general flying blind and you don't want to do that. The panel of genetic mutations for patients who do not have an identifiable mutation is expanding. We're trying to identify more genes that give rise to thyroid cancer. So hopefully in a number of years, we'll have additional mutations that have not been identified to date.
Does the TT level need to come down to 0 to be cancer-free?
After receiving radioactive iodine, any measurable thyroglobulin level means that there are microscopic cells of thyroid cancer producing this thyroglobulin somewhere in the body. So if the level is 0.3, 0.4, 0.5, that means that there is a tiny bit of thyroid cancer somewhere hidden, like in a lymph node in the neck or somewhere, and technically you cannot consider that person cancer-free. Not that you would have to do something about that, but I hope that answers your question. So that.
Is redifferentiation treatment used in young patients 18 or younger?
No trials have been done on younger patients. So none up to date, but the drugs can potentially be thought of for use in younger patients, yes.
Can a patient with low kidney function use these drugs?
Yeah, you have to titrate the dose of the drug to their kidney function.
Let's see, are there any late mutations such as P53 or P10 that you would consider not good candidates for redifferentiation therapy?
Yes. P53 and P10 mutations have locked the cells into undifferentiated states that with the drugs available to date, we haven't been able to redifferentiate them. The drugs available to date do not target these mutations. And so if patients with these genetic mutations may transiently respond to a BRAF inhibitor, they escape this response in 3 months to 6 months, and they progress despite a partial initial response. And so sometimes that happens, or sometimes what happens is they don't even respond to begin with. So we've seen that the use of BRAF inhibitors or MEK inhibitors in patients with certain types of mutations that lock the cells in an undifferentiated state cannot be redifferentiated.
Okay.
Working on that. Yeah.
My husband has HRAS mutation and was refractory. Very high thyroglobulin marker, 15,000. Just had a redifferentiation with
cobimetinib for 10 weeks at MD Anderson, and he ended up with thyrotoxicosis and was told that was an uncommon reaction. Know of other such reactions? How long before you generally know the actual outcome of redifferentiation treatment? So Well, what that tells you is that actually your husband redifferentiated a lot, because the cells not only ended up taking iodine, but also producing thyroid hormone, which caused this thyroiditis, thyrotoxicosis. And so in a way, I would say good for him. You should be very happy, because that tells you that the drug worked to make the tumor produce a ton of normal thyroid hormones. It typically takes about 6 months for you to start seeing, 6 months to a year for you to start seeing the initial response to these drugs. But I would give yourself a little bit more time and see if the thyroglobulin level after the cobimetinib and the radioactive iodine starts going down from 15,000 to 12,000 to 9,000 to 5,000, and follow it over time. I would say this is a good reaction to have.
Excellent. So we have 2 minutes left in this presentation here. Did you want to maybe stop it for questions right now, unless you want to continue?
Let's go. Let's answer as many as we can.
All right, why don't you read the next question yourself, because it's got a lot of letters and numbers
For
in
a
it.
poorly differentiated thyroid cancer, non-radioiodine avid who tried trametinib for 1 month, he's an NRAS positive along with the third PI3 kinase, IFAX, JAK, RBM10 from MSK Impact, and was unsuccessful with redifferentiation. Is there any chance of combining a MEK inhibitor and trying again for redifferentiation? You know, hopefully, ask Alan Ho and Eric Sherman coming up at 6 p.m. Yes, you know, trametinib is the one that was within trial for RAS mutant patients. You know, you can ask your oncologist at Memorial if they would be willing to give you the dabrafenib plus trametinib, the combination of two things, but you can already see that the burden of mutations with third and IFAX and JAK and RBM10 is such that there's a lot of additional mutations that we don't have therapies for, and it's challenging. Why couldn't we try selumetinib, the original host study that worked in NRAS patients on above patient? On the patient that I just read, trametinib is much more potent and effective than selumetinib. Selumetinib was not that potent as we learned later on. That's why. Both the low dose radioiodine scan and the FDG have been coming negative. We read this one. Is paraneoplastic syndrome common in radioiodine refractory cancer? Sometimes. Paraneoplastic syndromes can be manifested by high calcium or Cushing's or other types of paraneoplastic syndromes. I don't know which one do you refer to, if you can be more specific, but not necessarily like a sign of radioiodine refractoriness. If my thyroglobulin is always not higher than 2 and varies to 3, what point should a patient get a PET scan? Not dependent on the thyroglobulin value. Again, the thyroglobulin has to be progressing 2, 3, 4, 5, and not finding anything on neck ultrasound chest CT for you to try and find the disease on a PET scan. It's not the absolute value of thyroglobulin, it's the trend. If the trend is dramatically going up, that's when you do the PET scan. Looking towards the future of redifferentiation therapy, what is something you're particularly looking forward to? Combination therapies for these genetic mutations that we cannot redifferentiate. You know, at the moment, we have a whole bunch of mutations that lock the cells into undifferentiated states, and there is no way that we can redifferentiate these cells. And so I'm looking forward to seeing new drugs that can target some of this resistance. My original tumor, Hurthle cell, 3 years ago was never tested for mutations. Is there a way to determine if it was what? Rising TG lesions on iliac crest and lungs. So yes, so Hurthle cells have a very particular genome. They can be tested. In general, these are chromosomal abnormalities. Some Hurthle cells have RAS mutations. Your tumor can be tested. So yes, you can ask your doctor to test your tumor. What of you started with thyroglobulin level of 2,400 after total thyroidectomy, high dose radioactive iodine and low dose radioactive iodine and high neck dissection, metastasis to lymph nodes, and are on suppression, and 7 years thyroglobulin level is 37, no signs of metastasis. Is there anything to look into to get the undetectable point? No. So I had a patient just like you who remained with a thyroglobulin level of 37, 37, 26, 37. I scanned her left and right, and diagonally I couldn't find where the thyroglobulin is coming from. I would suggest continue to look, and one day you will find where the thyroid cancer or the thyroglobulin is coming from. And when you find it, you'll remove it with a surgery, and hopefully that thyroglobulin level will go from 37 all the way down to 5 or to 2. But yes, there are many of our patients that we cannot find where the thyroglobulin is coming from, and all it requires is patience and continued testing, because you may spend decades without knowing where the thyroid cancer is coming from. Does a negative radioiodine scan and negative FDG PET mean that the tumor is in the process of redifferentiation, and can a tumor be in the process of dedifferentiation over a period of 2 years? No, it doesn't necessarily mean that. It may mean that your lesions are very small for the radioiodine scan or the PET scan to pick them up. Or if the lesions are large enough, it may mean that you have a different type of tumor, or it may mean that if the lesions are large enough and growing despite a negative radioiodine scan and biopsy-proven thyroid cancer, that's already radioiodine refractory or dedifferentiated thyroid cancer. Negative PET scan is fine. One more. I thought I was done.
I thought so too.
7 lung nodules that are radioiodine resistant. 3 of the nodules are growing, and my thyroglobulin level is now 800. The largest nodule is now 1 centimeter, grown from 5 millimeters in 2 years. Iodine did not show uptake. Okay, so, we don't panic when the nodule gets to 1 centimeter. Honestly, we continue to look at the rate of progression of these lung nodules. It is important to understand that it took you 2 years to get from 5 millimeters to 1 centimeters, and not because you're at the 1 centimeter mark are you going to start using these redifferentiation therapies and stuff like that. Now, if you told me in 3 months your thyroglobulin level is 1,500 and these nodules grow to 1.3 centimeters and you start getting anxious, that's the time to start thinking of redifferentiation therapy. So, that would be my recommendation. Am I right in saying that all dedifferentiated thyroid carcinomas are radioiodine resistant, but all radioiodine resistant carcinomas are not dedifferentiated? More or less.
Excellent. We'll take that answer.
Good.
Dr. Laura Boucai, this is amazing. What a wonderful presentation. I think you set the record for the most questions answered.
Oh my
just
God.
keeping track. You have 39. I'll check with the officials and see if you can get a medal. But what a wonderful job presenting today. Thank you so much for answering everybody's questions. And
it was a pleasure. Thank you so much for inviting me. I look forward to doing this next year. If you want to have additional questions, my name is Laura Boucai. I work at MSK. Just get in touch with me and I'm happy to answer questions. Thank you all for attending this session.
Amazing. Thank you.
Have a great weekend.